What are the various clinical manifestations of leptospirosis? The types of presentations are two, Anicteric and Icteric. Anicteric leptospirosis is common. 95% of the cases of Anicteric leptospirosis are seen from the leptospiral infection, and recovery is the rule. Icteric leptospirosis, also called the Wheel syndrome. Remember, Wheel is the person who first identified this particular disease and described as early as 1886, and this Wheel syndrome is rare, fortunately, and some of these cases may become fatal. Hepatorenal syndrome, hemorrhagic syndrome with acute renal failure, atypical pneumonia syndrome, septic meningoencephalitis, myocarditis with heart failure, and chronic ophthalmic manifestations such as uveitis, iridocyclitis, etc. can occur. Remember, all these are not common, they are quite rare. The commonest presentation is Anicteric leptospiral fever, and which is very mild in its nature, and recovery is the rule. This diagram further emphasizes the two types of presentation, Anicteric presentation and Icteric presentation. 90% of the cases of leptospirosis are Anicteric. It is common, it is mild, and the mortality is less than 2%. Only 10%, 5 to 10% of the cases of leptospirosis are Icteric or the Wheel syndrome. Fortunately, it is rare. Some of these cases may become very severe, and then mortality to the tune of 5 to 15% can occur. This is a nice comprehensive chart to understand the disease and various aspects of the disease. The approximate time scale: 1 week, 2 weeks, 3 weeks, 4 weeks, months to years, and many years. The incubation period is 2 to 20 days. Inoculation of the leptospirae occurs, and the first week you have an acute stage with fever, which is due to the leptospiremia or septicemia. And then there will be a lull of about 2 to 3 days or 4 days, during which there will not be any fever, patient feels better. Again a second spike of fever occurs, and that is in the convalescent stage. This is called the immune phase. And the rarer complications of chronic features like uveitis, interstitial nephritis occur months to years after the initial infection. Leptospires, where can they be isolated? In the blood, of course, in the first week, in the CSF during the first week and the early second week, in the urine from the second week, third week, fourth week, and of course in the reservoir host, particularly the animals, it will be for years they will be excreting. Antibody titers: high, low, negative. So the normal response to the antibodies are: the first week there are no antibodies, the antibody starts appearing at the end of first week or the beginning of second week, and they plateau like that, and after a few years they come down. Whereas if we start early treatment within the first 5 days, the antibodies do develop, but the titer will be very low due to early treatment. Whereas some patients, they may show antibody titer which is not due to the leptospira, but due to an anamnestic reaction due to other infections. A small low titer of antibodies, just like the low idal titers, can occur, and this is not due to leptospira. Laboratory investigations, of course, the blood culture will be useful in the first week and the early second week and during the inoculation phase, whereas CSF culture in the late first week and the early second week, and urine examination, urine culture, of course, second week onwards throughout the course of the disease. Serology in the first week, difficult, sometimes you don't get many antibodies in the first week. From the second week onwards, second and third weeks onwards, serology is useful, and in the chronic patients also serology will be useful. So the phases of the disease are leptospiremic phase in the first week, leptospiruria, and then the immunity phase from the second week onwards throughout the duration of the presence of the organism. So this is in nutshell explains the various phases and the details about the leptospiral infection and disease in human beings. So we have seen that there are two types of clinical illnesses that can occur, the Anicteric illness and the Icteric illness. The Anicteric milder illness can present in two phases, leptospiremic phase and the immune phase. The initial leptospiremic phase, fever, myalgia, severe headache, conjunctival suffusion, abdominal pain, epistaxis, lymphadenopathy, rashes, all these common manifestations of any routine fever will be there. And after a period of 1 week, the fever subsides for 3 to 4 days, the patient will be afebrile. Then of course the immune phase starts, wherein the antibody titers start rising, and subsequently the patient may have milder fever, and the meningeal signs of meningeal irritation or meningism can be seen, and signs of uveitis and iridocyclitis. The incubation period for the disease is 5 to 14 days usually after the initial contact with the infected urine or the environment. Sometimes it could be as long as 3 weeks. So the leptospiremic phase is classically manifest in all the patients, whereas the immune phase may be manifest or may not be manifest in some patients, depending on the immune response. So this is in nutshell the presentation of cases in the Anicteric type. Icteric leptospirosis, the liver is the target organ there. Jaundice occurs in 4 to 6 days, usually in 2 to 9 days after the exposure. Serum bilirubin is markedly elevated compared to viral hepatitis. In viral hepatitis we see 2 milligrams, 4 milligrams, 5 milligrams, but not 20 and 40 milligrams. Here in icteric leptospirosis, marked elevation of serum bilirubin and a very mild elevation of the liver enzymes. The transaminases are not commensurately elevated as we see in case of viral hepatitis. In viral hepatitis, SGOT, SGPT are 300, 500, 1000, 1500, 3000 units, whereas serum bilirubin is low. Whereas here, marked elevation of serum bilirubin, very mild elevation of enzymes, and of course there will be elevation of alkaline phosphatase also very much in this particular disease. There may be intrahepatic cholestasis and hepatocellular necrosis in some patients. Death, if it occurs in a patient of leptospirosis, of icteric leptospirosis, it is not due to the liver disease but due to other complications like hemorrhage, renal failure, hepatorenal syndrome and pulmonary involvement, and usually it is not due to the liver failure. Usually patients who do not have pulmonary, renal or cerebral involvement or hemorrhagic bleeding tendencies, if they have only icteric leptospirosis, they recover usually because the liver function recovers markedly. What will be the effects on the kidneys in cases of icteric leptospirosis? It could be mild to severe. Urine analysis shows hematuria, pyuria, proteinuria. Renal failure can occur. Prerenal azotemia, acute tubular necrosis, acute autoimmune nephritis. Autoimmune nephritis or acute tubular necrosis can occur. The renal involvement is mainly due to the immune phase. The patients may be oliguric or non-oliguric. The mechanism, nephrotoxicity due to endotoxin, direct bacterial migration and toxic metabolites can damage the kidney. Hypoperfusion and hypotension, fluid loss and fluid shift can also result in kidney damage. GI bleed and myocarditis may be accompanying. Patients with severe disease may come down with hemorrhagic manifestations. Hemorrhagic fever due to vascular injury, vasculitis, as we have already seen, the main pathogenic mechanism in serious disease is small vessel vasculitis. Respiratory, alimentary, renal and genital tracts may show hemorrhage. More common in icteric and with renal failure, reported mostly in Korea, Andaman Islands and in Brazil. Hemorrhagic pneumonitis with hemoptysis, acute respiratory failure, chest X-ray may show single or multiple ill-defined opacity. Picture similar to atypical pneumonia, occurs in the second week or as early as 24 to 48 hours in some cases, usually occurs in the second week. Of course, hemorrhagic pneumonitis or aseptic pneumonitis picture is reported from Korea, Andamans and Nicaragua. This is an X-ray picture of a patient with atypical pneumonia due to leptospirosis. You can see here both the lungs have patchy consolidation, bilateral diffuse patchy consolidation. Shadows are seen in both the lung fields. The left lung more affected than the right lung. Pneumonitis picture, not a typical consolidation of lobar pneumonia, but an extensive bilateral patchy woolly lesions simulating a typical pneumonia. In this particular patient, this picture of pulmonary involvement is due to leptospirosis. So, what are the cardiac manifestations of leptospirosis? Hemorrhagic myocarditis, arrhythmias, cardiac failure, hypotension and death can occur. Atrial fibrillation and conduction defects may be seen. ECG changes sometimes may resemble non-specific STT changes may resemble acute coronary artery disease like ECG. Remember, the patient has got other features of leptospirosis, fever, and then the immunology will be positive, and the non-specific STT changes should not be confused with coronary artery disease. Sometimes patient may show low voltage complexes due to pericardial effusion or due to myocarditis. This is reported in Sri Lanka, in Barbados and in Portugal. The other manifestations of leptospirosis are aseptic meningoencephalitis. Aseptic meningoencephalitis, it is rare luckily, it occurs in the immune phase of the disease. CSF shows increased proteins and increased lymphocytes. Convulsions, picture of encephalitis, myelitis and polyneuropathy can be seen. This is a sort of serious presentation of leptospirosis, but in general the milder cases will have meningism. They have mild neck rigidity, they may have little vomiting, they may have headache, but classical meningoencephalitis will not be there, and there are features of meningism occurring in mild cases of leptospirosis, whereas the severe cases will show aseptic meningoencephalitis. The ocular manifestations of leptospirosis are late complications. Conjunctival suffusion, subconjunctival hemorrhage is very common in cases of leptospirosis. Anterior uveitis, iritis, iridocyclitis, chorioretinitis can be seen. It occurs in 2 weeks to 1 year after the onset of clinical illness, and average duration for the ophthalmic manifestation to occur is around 6 months.